Good morning. Thank you, Sages, for the opportunity. I have no disclosures. Get my time to start. Yeah, thanks. Your problem. Thank you. All right. I think a lot of us have been in this situation where you've got a young patient who comes to you. They've been in an MVC, maybe high speed, maybe not, but thankfully they were wearing their seatbelt. And although we know that seatbelts save lives, we also know that it can end up in abdominal wall injury. So in this patient, as an example, MVC, relatively high speed, but hemodynamically stable and underwent a CT scan. And this is what you find. So you can see complete disruption of the left abdominal wall in the flank region with complete disruption of all three layers, your external oblique, internal oblique, and transversalis. And you even see bowel now that is herniating through that defect. And in addition to that, though, what you also see is edema, fat straining in the abdomen, some free fluid, maybe some questionable concern for small bowel injury. As we know, CT scans aren't the best at picking that up. And so the question then, I think a lot of us have been, well, maybe if there's free fluid, maybe I will take them to the OR, maybe I won't, I don't know, what are we going to do with this? And so to back up for a second, really look at abdominal wall injury. Again, not only is the incidence increased since the use and enforcement of use of seatbelts, but in addition to that, we've just been able to find it better, do the modern era, and we CT scan almost every trauma patient now. Overall, the incidence is 9%, with about 15,000 traumatic abdominal wall hernias a year. And I'll come back to that number here in a second. And there are different grades. Grade 1, just a bruise, basically, all the way to grade 6, where you have evisceration of intra-abdominal contents out of the abdominal wall. But really, I think a lot of us, the 4s and 5s are the ones that create the quandary. In other words, you have a complete abdominal wall muscle disruption. These can occur not just in the flank, but also through the rectus, and even you can get a lumbar hernia as well. So this is grade 4. So similar injury to what we saw before, but you see that there's no evisceration of contents. And I'm going to come through in a little bit and talk about what I would do in that situation. And then this is the grade 5, where you do have herniation through the abdominal wall defect. Now, even though, as I just mentioned, there are 15,000 of these a year, the literature is really lacking. Prior to 2021, there were the two largest series in the literature. One had 34 patients, the other one had 80. It's not a lot to really gather consensus on, as we've seen throughout with hernia care, that is the consensus, that oftentimes there is none, and especially in this situation. And in 2021, the Western Trauma Association published a retrospective multi-center, and even with as many centers as they had in this series, the entire series was, again, only 281 patients. Now, how I became interested in this was because I felt like when I got these patients, there was no herniation through the defect, and you weren't sure, there wasn't any obvious intra-abdominal injury. Do I operate on them just because they have the hernia? Do I not? What do I do with this? And so a lot of what the data has been aimed for or aimed to do is just describe what other injuries we are finding. And so in the Western Trauma Association paper, bowel resection happened in about 44% of patients that underwent surgery. The average size of these defects are big. It's 10 centimeters. Okay. And what they found, which was interesting, was that there was no difference in recurrence. So in these patients who went to the operating room, they had surgery and they were repaired either early or late, there was no difference in recurrence. And that is surprising for a couple of reasons. One is, again, we're talking about the size of defect. This is 10 centimeters. This is not small. The second thing is we've got to think about the etiology of this defect, right? A lot of what we've been talking about in this course is risk of recurrence in normal tissues, like in chronic hernias. Maybe there's not even any active inflammation at all. These defects occur from the muscles being torn apart. These tissues are friable, they are mangled, and so that has been one of the questions, and I still think we don't 100% know in terms of the recurrence rate when you do these early versus late. This is from my paper that had the 80 patients, but overall you can see the associated injuries are overall high. But there are patients that you can do non-operative management. So we put ourselves back into the trauma bay and we see this patient and we have this CT scan. Now, what are we going to do about it? So overall, you can see that the non-operative rate ranges anywhere in these case series from 12% to 37%. So overall, if I have no evidence of intra-abdominal injury at all, then to me the question then becomes, do I have contents that are herniated through the defect or not? If I do not have contents that are herniated through the defect, I will non-op them. And when I say non-op, I mean I will admit them and do serial abdominal exams. As we've discussed, CT scan's not always great about picking up small bowel injuries, especially in trauma, okay? So no other signs of injury, there's nothing herniating through the defect, I'm gonna admit them, do serial abdominal exams. If, like the CT scan I showed earlier, it's a grade 5 where I have intra-abdominal contents that are herniated through the defect, I do operate on them because I have seen these defects become a point and source of obstruction in patients. So I want to return those contents back into the abdomen. And what you'll see, so again, fairly large range of non-operative management for these. Overall, again, anywhere from 33 to 60% rate of bowel injury. So we talk about you can expect some contamination with these. And overall mesh repair. So again, some of these studies, as you can see, they didn't even delineate between primary or mesh, but overall your recurrence rate anywhere from 7 to 27%. I will say too, again, the majority of these series have been done in trauma patients and our rates of follow-up are traditionally lower in our population. So again, I think these recurrence rates, if anything, are underestimated. This was specifically in our 80 patients, what ended up happening, just to take a look at acute versus delayed repair. And overall, again, the numbers were small, but it leaned towards having delayed repair versus acute. But to back up, I'm going to talk about what do I do? All right, if I'm in the operating room and I'm in there because of intra-abdominal injury and I find one, or if I don't have evidence of intra-abdominal injury, but I had intra-abdominal contents herniating through the defect and I'm in the operating room. I do single incision surgery mostly, and it's a midline laparotomy. I'm very proud to say that and uncomfortable up here in my minimally invasive colleagues' audience. But I think the main thing to remember is keeping it simple, remembering why you're in the operating room. If I'm in there for other injuries, that is my focus. Again, these patients, if they've had enough force applied to their body to completely rip their abdominal wall apart, they can be sick. And I say that because especially these can be ugly. I mean, you can get these CT scans and it is impressive. And what can happen is it diverts your attention away from the physiology of the patient and even potentially from the other injuries that this patient is having because everyone's focused on what's ugly. They're focusing on this big traumatic abdominal wall. So the very first thing is remember why you're in the operating room. You're there because the patient's been through a trauma. Keep the trauma number one. The second thing is remembering then my goal. My goal at the time is just to keep intra-abdominal contents intra-abdominal. I don't want that defect to then become a source of obstruction later down the road. And again, as was mentioned by my colleagues in previous lectures, you just don't want to burn bridges. These tissues are extremely friable, and overall, I quote patients anywhere from a 30 to 50% recurrence rate, just depending on a variety of things. We're talking about BMI, smokers, substance abuse, and again, just the trauma itself. So if I can close it, primarily, that is what I do. And I repair it in as many layers as possible. Now, some people will tell you, or some people have done, where they will actually open the overlying skin over the hernia defect to try and get maybe a different layer. I personally don't do that, and I recommend against doing it. Again, these tissues don't hold suture well. It's literally your meat that's been through a meat grinder and you're trying to suture it. So the things that I have seen from that is where if things start to break down, including the skin overlying it, you potentially now have a much bigger problem. So in general, I do not open the overlying skin over the defect. I close in as many layers as possible. Then I do a wide intraperitoneal underlay. I typically use Vicryl, something absorbable, again, just to help bolster the repair. If I can't get it closed, and again, these can be very tricky because oftentimes where these tissues rip are against a point of fixation, such as the iliac crest, iliac wing, such as ribs. And so these can be tricky, and there are times where you're really struggling to even get sutures. So again, there are times I've placed pericostal sutures where it has ripped completely off the inferior aspect of a rib. I don't sew through the rib, I go above. But even for the iliac wing as well, I've even had to call orthopedic surgeons at times to help me anchor mesh or tissue to bone. So just keeping this in mind, but if I can't close primarily, wide placement, an underlay absorbable mesh, interrupting sutures are fine, or a laparoscopic tacking device. And again, really the next thing is going to be patient education, really letting them know this was a temporary, potentially only a temporary fix. We're going to keep a good eye on you, and they should not be lost to follow-up. I think then if it recurs, then you can get into more complex repairs. Thank you so much.